The listening part of the occupational English test has 3 parts, and in each part you will hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You will have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 different extracts. In each extract, a healthcare professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for extract 1.
You're an optometrist talking to a patient called Aidan Fitzpatric, who has been experiencing blurred vision.
Hi Aidan, I'm Dr. Salkeld. Could you start by telling me about what's been going on with your vision?
Sure. Well, I guess it must have started a while ago, but I didn't really notice it properly until about 2 weeks ago. I was working in my garden and I noticed that I was having a hard time reading the instructions on the gardening products that I just bought. I normally stick to the one I've been using for years, but I thought it'd be nice to try something different. Anyways, it kind of felt like everything was fuzzy around the edges and I just couldn't see the letters clearly. After talking to my daughter, she mentioned that I've been using increasingly more light to read at night and even pulling things closer to me to read. I hadn't even noticed. So I went out and got some of those glasses they sell at the pharmacy and they helped, but my doctor said that it'd be better if I came to see an eye doctor. Well, they made things less blurred anyway, I guess. My vision's still not crystal clear or anything when I use the glasses, but I wasn't really expecting that. I still notice that I'm squinting to see things. It's mostly when I'm trying to read something close up, like small writing. I'm better when things are at a distance. I don't know if it's related, but I've also noticed a pretty persistent headache. I guess it's kind of at the sides of my head, I suppose. It comes and goes, but it's definitely worse when I'm having trouble seeing something. When it gets really bad, I just take a fast-acting ibuprofen and that tends to sort it out.
Ever had any vision problems before?
When I was little, at some point in elementary school, I think I had glasses, but I'm sure I broke them and we just never got round to having them replaced. My brother has glasses that he's been wearing for years. I don't really know a whole lot about what's wrong with his eyes. Maybe he's short-sighted. Oh, but that reminds me. My brother thought I should mention that a couple of months or so ago, I was pretty ill. I was suffering from sinusitis. And anyway, I left it pretty late to go and see the doctor about it. Kind of thought that it would just sort itself out. Anyway, it lingered for a while, so when I told my doctor, he gave me some antibiotics and it cleared up pretty quickly after that. Well, for the most part, although I still feel like I have a cold. Other than that, I've been in really good health for the last few years. I take my health really seriously. I'm not sure if the doctor told you, but I used to be quite overweight. But I lost it all after a bit of a wake-up call some years back. I had what you guys call a myocardial infarction. It was pretty scary and I was quite overweight at the time and really stressed out about my job. Since then, I've made a real effort to look after myself properly.
I'm glad to hear it. So, in terms of your blurred vision, what do you think might work for you?
Well, I don't particularly like the idea of wearing glasses all the time, but touching my eyes freaks me out, so contact lenses are definitely not an option. I guess the best thing might be to just have glasses that I wear all the time, so I don't keep forgetting to put them on when I'm out somewhere, not at home. I've actually never had an eye test, so I should probably schedule one of those as the next step.
I think that sounds reasonable. Let's do some tests to check out your eyes and go from there.
Now look at the notes for Extract 2. Extract 2, questions 13 to 24. You hear an optometrist talking to a patient called Marcia Samarina. For questions 13 to 24, complete the notes with a word or short phrase.
Now, Jane, just before we begin, can I start by asking you your age?
I'm 25.
Okay. And what brings you in today, Jane? What's the problem?
Well, I've been feeling a bit tired for the past few weeks, and I don't seem to have much energy to do anything, really. And I was wondering if you could tell me what's wrong with me.
Okay. Well, tell me a little bit more about it.
Well, I started to get tired about 4 weeks ago, and it's really persisted since that time. And I've actually had to stop playing netball because I've been so tired. When it started off, I had some aches and pains in my muscles, and but they seem to have settled down now, and it's really just the tiredness that's persisting. And I've got exams in a few weeks, and I'm really worried that I won't be able to study properly because I'm feeling so tired.
I see. Goodness, that must be very distressing for you.
Yeah, it's really worrying me.
Yeah. What are you studying?
I'm a social work student.
I see. Well, tell me, apart from the aches and pains that you noticed initially with this illness, was there anything else in particular that you'd noticed?
Well, it sort of started quite suddenly, really, and when it started, I had a bit of a cold, a bit of a blocked up head and a runny nose. And I actually went to the doctor at Student Health at the university, and he said I just had a virus and I didn't need any treatment and it would go away. And he didn't do anything else than that, really.
Right, okay. So at the moment, just to let me clarify again, the main problem now is tiredness. All of the other symptoms have settled down.
Yeah, just really tired, and I can't do anything, really.
Right, okay. Well, just before I actually start examining you, can I ask you a few just general questions before we get started, okay?
Mm-hmm.
What's your appetite and weight been like?
My appetite's been fine. I've been eating the same amount, and my weight's steady.
Okay, and have you been running any fevers recently?
No. 4 weeks ago when I had a bit of a cold, I thought I had a bit of a temperature then, but nothing now.
Okay. And your bowel habits?
I've been regular.
Regular, that's good. All right, well look, I think at this stage I'd like to have a bit of a look at you, and we'll talk about things after that, okay?
All right.
Right, Jane. Having had a look at you, I think really the major things that are noticeable are that you've got some scattered glands around your body, okay, those lumps that I felt in the neck, armpits and down in the groin regions, and you may have also noticed a bit of discomfort up in the left side of your abdomen high up when I was feeling. And that is the site of an organ called the spleen, which is also a type of gland which is also enlarged, okay?
So what does that mean?
I think all of these really point to some form of viral illness, quite possibly glandular fever.
Okay. I was just going to ask as well, are you absolutely sure it's glandular fever?
It's highly suggestive, okay. I can't be totally certain at this stage without really doing some tests to confirm it, and I think that would be a good idea to do.
What sort of tests are they?
It's a blood test, and it will involve a small sample of blood being taken. Really, what I'll do is do a specific test for glandular fever as well as looking at your blood in general to make sure that there are no other possible problems there.
And that can tell for sure if it's glandular fever?
Yes, that's correct.
Right. And when you do the blood test, can you see if I'm anemic as well?
Yes, certainly. Is that a particular concern of yours?
Yeah, well, I've been having all those ads on the TV, about if you don't eat enough meat, then you might be anemic, especially if you're tired. And I was wondering if that was my problem as well.
Okay, I mean, tiredness certainly can be one of the symptoms of anemia, and I think it's justified that you're concerned about it, particularly given the publicity that we've been having, but I can fairly confidently reassure you, just on having examined you, that that would be very unlikely in your case. Okay, but we can certainly run that test, and in fact I was going to run that test as a routine anyway.
Oh, that's good.
Right. What you need to do really at this stage is rest. Okay. There are no specific remedies that I can give you for this illness. We can't cure it. Your own body will cure it by fighting it off, but that will take a bit of time. How long exactly? Again, I can't be certain. Hopefully within the next week or two you'll be feeling a lot better, but that's something that we're going to have to keep an eye on. At home, really, you need to keep up your diet and keep up your fluid intake, and really we're going to have to organise to meet again and just make sure that this is slowly settling with time.
That is the end of Part A. Now, look at Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion between a doctor and nurse about different complications following heart attack.
Hello, doctor. What types of complications are expected following heart attack?
Well, there are 2 types of complications that can occur following a heart attack. The first problem occurs pretty much straight away, and the second complication occurs later on. Immediate complications following a heart attack are: arrhythmias is the immediate complications in which the heart beats irregularly, either too fast or too slowly. Cardiogenic shock is when the patient's blood pressure drops suddenly. Therefore, the heart cannot supply adequate blood for the body to function properly. Hypoxemia is the condition when the oxygen levels in the blood become too low. Pulmonary edema occurs when the fluid accumulates in and around the lungs. Deep vein thrombosis occurs when the deep veins of the legs and pelvis develop blood clots that either block or interrupt the flow of blood in the vein. Myocardial rupture occurs when the heart attack damages the wall of the heart. That has an increased risk of a heart wall rupture. Ventricular aneurysm is when a heart chamber called a ventricle forms a bulge. Question 26. You hear the discussion between 2 doctors about the impacts of acute kidney injury.
What are the impacts of acute kidney injury, doctor?
Acute kidney injury is a common and severe complication of surgery, especially cardiac surgery. Often, the complication is associated with higher rates of morbidity, mortality, and cardiovascular events, longer hospital length of stay, and higher cost. During stage 1, there will be an increase in serum creatinine of 1.5 to 1.9 times baseline, an absolute increase of at least 0.3 milligrams per deciliter, or urine output of less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. During stage 2 of acute kidney injury, there will be an increase in serum creatinine of 2.0 to 2.9 times baseline, or urine output less than 0.5 milliliters per kilogram per hour for 12 or more hours. During stage 3 of the condition, there will be an increase in serum creatinine of 3 times baseline, an absolute increase of at least 4 milligrams per deciliter, initiation of renal replacement therapy, urine output less than 0.3 milliliters per kilogram per hour for 24 hours or more, or anuria for 12 or more hours. Question 27. You hear a discussion between two doctors about acquired melanocytic nevi.
Hello, doctor. What are acquired melanocytic nevi?
Acquired melanocytic nevi are clumps of melanocytes that originate during childhood but manifest during 30 to 40 years of age. Junctional nevi form macules, with the skin markings becoming slightly more prominent. They are circular flat lesions with a uniform brown coloration. They have lentiginous cells, which are round or oval or spindle-shaped. Dermal nevi are raised pale brown or skin-colored lesions, and often hairy, having focal globules and fine vessels or pale areas. Pseudo-horn cysts may be seen. The cells are epithelioid with amphiphilic cytoplasm, and the melanin is in granules. Compound nevi may be raised with a wart-like surface in certain cases, and are usually lighter brown than junctional nevi are. They have round or oval globules of pigment, and these may form cobblestone patterns. Question 28. You hear a discussion between a doctor and nurse about amblyopia.
Hello, doctor. Can you explain what is an amblyopia?
Well, amblyopia is the medical term for lazy eye that refers to a condition in children where the vision in one eye fails to develop adequately. This usually affects the ability of the child to see using the weaker eye. In strabismic amblyopia, a squint develops due to a mismatch between the muscles that support the position of the eyes. Therefore, the brain ignores the eye that is not straight and relies on the images generated by the stronger eye. In a condition called anisometropic amblyopia, the refractive error is greater in one eye than the other eye. Therefore, the brain ignores the more farsighted eye and relies instead on the eye that provides a clearer picture. However, the weaker eye remains straight. Therefore, the defect may go unnoticed by the parents or primary care doctor. In the condition called deprivation or occlusion amblyopia, one eye is deprived of vision due to the development of a blockage, such as a cataract. The ocular media becomes opaque, preventing visual information from reaching the brain. Question 29. You hear a discussion about miliaria.
Hello, doctor. What is miliaria?
Well, miliaria is the conditions associated with sweat retention in the skin. When the flow of sweat is obstructed, the sweat stays trapped within the skin instead of moving out from the sweat glands to the surface of the skin, developing various symptoms and signs, including skin lesions. Miliaria crystallina, also called pseudomina, describes sweat duct obstruction in the uppermost epidermis. where the sweat is retained to form subcorneal vesicles. These clear, non-inflamed, fluid-filled blisters and papules rupture easily, and even light rubbing can cause them to break. Miliaria rubra, also called prickly heat, and refers to the retention of sweat that moves into the middle layers of the epidermis and the upper dermis, resulting in itching and redness around the sweat pores. Miliaria pustulosa occurs when the miliaria rubra develops as inflamed pustules. Miliaria profunda occurs when the sweat moves from the ducts into the dermis. Hard, flesh-colored, painful papules develop that are much larger and more deeply located than the papules seen in miliaria rubra. Question 30. You hear a lecture about different type of stents. We see today what is stent and what are the different types of stents. Stent is a splint that is placed inside a duct, blood vessel, or canal temporarily to aid healing or relieve an obstruction. Primarily, they are used to keep narrowed blood vessels open and patent, to allow sufficient blood flow or bodily fluid. Coronary stents are a tubular, mesh-like device that do not have any embedded medications in them. Drug-eluting stents are coated with medications to prevent inflammation and retinosis of the artery on a long-term basis. A urinary stent is used to hold open the ureter in cases where it is narrowed. Ureters are long tubes that carry urine from the kidneys to the bladder, where it is stored until it is emptied. Urethral and prostatic stent is used to open up the narrowing caused by an enlarged prostate pushing against the urethra, preventing the normal outflow of urine. Peripheral vascular stents are used to keep blood vessels outside the coronary arteries open. Stent grafts are tubular devices made up of a special fabric that is supported by a rigid metal stent. These are mainly used for vascular surgeries, such as to repair abdominal aortic aneurysm. Stents can also be used to keep the food pipe of the esophagus open in case of esophageal constriction, and biliary stents can be used to maintain adequate drainage of bile into the intestine.
This is the end of Part B. Now, look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer, A, B, or C, which best fits according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, for questions 31 to 36. You hear the lecture given by a physician on the standard method of diagnosing attention deficit hyperactivity disorder. You have 90 seconds to read questions 31 to 36. The standard methods of diagnosing and assessing attention deficit hyperactivity disorder used by mental health professionals is application of the criteria established in the Diagnostic and Statistical Manual for Mental Disorders that identifies 3 presentations of attention deficit hyperactivity disorder: combined presentation, predominantly inattentive presentation, predominantly hyperactive impulsive presentation. Functional neuroimaging, such as SPECT scanning, is considered an effective tool for researchers. Type 1. Classic attention deficit disorder. People with classic attention deficit disorder have reduced blood flow in their brain area of the prefrontal cortex, cerebellum, and basal ganglia. The basal ganglia produces dopamine. Type 2. Inattentive attention deficit disorder. People with inattentive attention deficit disorder are often described as daydreamers, space cadets, and couch potatoes. This type is more common in girls than boys and is often diagnosed later in life because people with type 2 inattentive attention disorder don't have behavioral problems. People with this disorder have reduced activity in the prefrontal cortex as well as low levels of dopamine. Type 3. Over-focused attention deficit disorder. People with over-focused attention deficit disorder have a deficiency of dopamine and serotonin. The aim of treatment is to increase both these neurotransmitters, the nervous system's chemical messengers. Type 4. Temporal lobe attention deficit disorder. People with this type might see or hear things that are not there, and learning and memory problems may be present. The patients will have irregularities in their temporal lobes and less activity in the prefrontal cortex part of the brain. The aim of treatment is to soothe neuronal activity and stop nerve cells from overfiring or firing unpredictably. Type 5. Limbic attention deficit disorder. People with limbic attention deficit disorder have excessive activity in the limbic section of the brain, which is where moods are controlled. They have reduced activity in the prefrontal cortex, both when relaxing or focusing on a task. Type 6. Ring of fire attention deficit disorder. People with ring of fire attention deficit disorder have an overactive brain. There are excessive amounts of activity in the central cortex and other areas of the brain. Type 7. Anxious attention deficit disorder. People with anxious attention deficit disorder have high levels of activity in the basal ganglia that aid in making dopamine. This differs from the majority of the other attention deficit disorder types, which have low activity in this part of the brain. It is possible to have more than one of these types of attention deficit disorder. For example, a common combination is overfocused, limbic, and anxious types.
Now turn over and look at Extract 2. Extract 2, questions 37 to 42. You hear a presentation in which a researcher called Dr. Milan Petricevic is talking about the relationship between new technology and medicine in the future. You now have 90 seconds to read questions 37 to 42. Hi, I'm Dr. Milan Petricevic, and today I'd like to talk about the future of medicine, particularly in relation to the current technological revolution. To many of us, it seems inevitable that medical robots, automation, and artificial intelligence will replace many jobs in healthcare. Surgical robots are becoming increasingly more precise, and right now, man-sized robots can lift and move patients and transport them throughout a hospital. Silicon Valley investor Vinod Khosla once said technology would replace 80% of doctors because machines will be more accurate, objective, and cheaper than the average doctor. He added that eventually we won't need doctors at all. However, I disagree. Instead, I think technology in some specialties will finally allow doctors to focus on what makes them good physicians, treating patients and innovating, while automation does the repetitive part of the work. So let's look at some examples of how different areas of medicine will benefit from current technological advances. Take general practitioners as an example. Many doctors choose this specialty today because they have a chance to make a long-term impact on someone's life. And it's true that GPs enjoy tremendous trust from their patients. But seeing someone only when they are sick makes it hard to prevent disease and ensure someone's long-term well-being. It's even harder to do this when waiting rooms are overflowing and you only have 15 minutes to diagnose the illness, design a therapy, and offer health advice. In the future, wearable sensors and devices that stream data to a doctor's smartphone will notify them whenever vital signs are acting up and provide them with all the data they need wherever they are. These devices will also ensure doctors only treat patients who really need professional care, making it possible to offer simple treatment advice remotely. In turn, this will increase the time GPs have to treat and advise each patient, building trust and ensuring patients act on a doctor's advice. What's more, smart algorithms will allow GPs to tap expert advice on their patients' conditions and act as a gatekeeper, connecting patients to other specialties. And these are just a few examples. So what about radiology? Well, already IBM's medical sieve shows how artificial intelligence algorithms can scan hundreds of radiology images in seconds, doing the repetitive job of finding malignant or out-of-place phenomenon that currently radiologists have to do daily. This technology won't replace this important specialty. Instead, radiologists will have time to supervise how the algorithm is doing, or to research and innovate, making the technology behind these devices even better. Their time will be much more productive, rather than spent checking hundreds of x-rays a day. Ophthalmology will bring science fiction technologies to patients in the near future. Retinal implants might give vision back to those who have lost it, or even give humans supervision, augmenting what we can already do. In sports medicine and rehabilitation, the first forms of activity records from tech like Fitbits all focused on people who exercised regularly, but only provided basic insight into how they were performing. Now, a new generation of devices tailored to professional athletes is hitting the market, with apps providing detailed insights into movement patterns and force output in any movement. Sports medicine physicians will have concrete data to measure how athletes are improving. By the time these reach the mainstream public, sophisticated algorithms will be ready to analyze data from these devices and provide personalized suggestions to improve performance and to speed up recovery. Similarly, video consoles from Xbox to Microsoft Kinect will offer a way of monitoring how a patient is doing from a distance by seeing their progress liquidly on a screen. In oncology, this specialty will pave the way for personalized medicine. Even now, oncologists customize therapies to a patient's genetic background and their tumor's molecular makeup. Cheaper genome sequencing and measuring blood biomarkers are speeding up this process, with companies like Grail working on fluid biopsies which could filter tumor cells from blood samples. Tumors could soon be diagnosed earlier and analyzed without costly surgery. What's more, artificial intelligence could soon be used to help oncologists understand and even cure cancer. Already, IBM Watson obtains all the relevant information from millions of studies about a patient's case and makes suggestions for treatment plans most likely to work. In the meantime, patients are better informed about the disease thanks to social media communities of fellow patients. These signs all point to a bright future for oncology in partnership with new tech innovations. So what does this all point to? Well, my conclusion would be that, all in all, many jobs will be taken over by robots and automation in the coming years, but at the same time, amazing opportunities will also emerge, especially in medicine. These will require physicians to acquire new skills and improve their existing ones. In my opinion, the majority of specialties will have more time for patients and better insight into disease.